All right, we are going to get started again. I think Dr. Purdy's going to go ring the bell out there. So everybody gather around. We don't quite have the audio feed up, so Judy's going to send out some info on that in the chat for those that are online. They probably can't hear me anyway, but at least they can see we're up here. So the next person is Dr. John. He wrote very few things. In fact, he didn't even write out his whole name. He wrote Dr. John Hatt. I think we'll call you Hatanelas.
All right, fair enough.
And he's a very humble man, as you all know, so he only wrote 3 things on his piece of paper for how to introduce him, so I think I'll embellish that a little bit. So he's originally from Cheyenne, Wyoming. He's been in this part of country a long time, has family out here. He did his residency and fellowship at Ohio Health, which is not in South Dakota, in case you're wondering. And it says he enjoys rock climbing. But beyond that, John was with us for a few years. He had some life choices to make, which took him back to Ohio, so we miss him greatly. But he was always a solid human being and a good person who took good care of his patients here in our Black Hills area for a few years. And we're happy to have him back to give us a little bit of a lifestyle talk. He's got a poll everywhere thing he's going to try to work. I'm sure that technology will be perfect. And we'll go from there. Thank you, John.
Awesome. Thanks for having me. Appreciate it. So in making this talk, I was kind of going full circle because when I graduated, I was really med-heavy, lipid-bound, like this is the only way we're going to treat disease. And it's just been kind of a paradigm shift from those first sentiments that I voiced at our first conference I presented at in 2019. So I kind of want to go through a subject that I think a lot of us don't know enough about, which is risk. And I just wanted to put this nostalgic image up here. This is when I interviewed, and I was reminded today that on my way out here to interview, I lost my luggage, or I shouldn't say I did, the airline did. So I was walking around in scrubs and had to temporarily borrow a Pradon suit, and it was just good. But that was my dad. This was before I was with my wife, and I asked Schaubauer if he could come with me, and he was amenable to it. And they talked a lot about cars at dinner. So, but this talk mostly is going to be about risk and just kind of going over when we're giving patients all these pills, what are we telling them, and how are they understanding it, and are we conveying it in a way that really makes the most sense? So this would be the first poll everywhere question. If anybody wants to fill out, if it'll work. Oh, it may not work. Let's see. Responses. So there's none coming in. Can we, let's see. Any thoughts? Sorry, we played with this for hours last night, and we still haven't figured it out, apparently. Mouse is in. But the responses aren't popping up. Sorry, quick technical difficulty. Oh, I mean, I can. Yeah, but the, oddly enough. Did we like reset it? Oh, the first question. So, yeah, but there's no answers popping in. Did anybody submit an answer by chance? Let's see. Oh, here we go. That's right.
John, can we back up to the QR code, make sure everybody had a chance to get into it?
Okay, I think we got it. All right. So maybe resubmitting, if you could.
Can you back up to the QR code?
Oh, yeah, definitely. Sorry. There you go. Yeah. Technology is not my forte. Let's see. It's odd. It's well, it was worth a shot. It looks like a couple went through maybe, but anyway, we'll kind of walk through this and revisit this question. So when we're talking about risk, we often quote either absolute risk or relative risk, and there's a fairly decent difference in how these are presented. And absolute risk in general is a smaller number, more reflective of what the actual data is showing, where when we start talking about relative risk, we start maybe over calling something or overinflating something. And some answers are coming in here. So this was a great book that kind of opened my eyes to the limitations physicians he really targeted in terms of how we interpret data and think about these numbers. Definitely a book I'd encourage anybody to look into, though. But this was an example of something that was fairly egregious and taken way out of context in terms of relative and absolute risk. So this birth control pill, this new iteration of the drug comes out, and it's reported as a 100% increase in blood clots. So if you hear that, you're probably like, well, shit, I'm not going to take that. I don't want to have blood clot. So this resulted in quite a bit of things happening, abortions particularly. This was in the UK, and there's some great articles on the repercussions of this to reference, but it's kind of like, how did this result? So if you just look at the data, second generation drug, 1 in 7,000 people are going to get a blood clot. If they take the drug, the third generation, 2 in 7,000. So that's 100% relative risk increase. So it's like, wow, if the media gets a hold of that, geez, that's a big deal. Like, nobody wants to deal with that. But the absolute risk is exceedingly low. And I think we've all lived through some times now where maybe we don't appreciate risk quite as much as we should. So this is, I kind of want to dive back into where did statins start and then progress to where are we at now with these newer therapies. And this was the original trial. This was the 4S trial. So the data is laid out here with statins, and this is driven by, it's all-cause mortality driven by cardiac death with an absolute risk reduction of 3.3%. Relative risk 30%. So I was thinking back to when statins were kind of first being touted as the go-to. If you told somebody that they had a 3% chance of not dying or a 10% chance of having myalgias, because that's kind of, we weren't sure back then, or aches and pains and poor quality of life potentially, probably wouldn't sell the drug very well. So then it's like, well, we tell the relative risk, I think is kind of how things shook out. And it's still reasonable, though. All-cause death is a big deal. Cardiac death, even 3% seems reasonable. We'll kind of dive into that. So remember, too, when you're talking to people, it's not everybody going to benefit from the drug. There's always a number needed to treat, and I think that's something I didn't appreciate until later in life, seeing some of the ramifications of some of the stuff that happens when we give people medications. Not everything is truly going to benefit somebody. In fact, it can sometimes come with consequences. So I think it's important just to recognize the power we have when we tell people to take something. And I've noticed with my trainees now at my new hospital that we just very underappreciative of this. It's just kind of, you go to the guideline, you give the drug. You go to the guideline, you do this. And we don't really know necessarily what the consequence of that might be always. So then this was an example. So it was the 4S trial, and then CARE came out and showed that no death benefit with pravastatin. But I thought this was a salient feature in that they followed this up because it didn't show death. They checked pravastatin, though, in the Lipid trial to show death benefit in a larger population of people. So it wasn't just an outcome of myocardial infarction, which I think we'll get into the weeds of a little bit. What does that really even mean? So I think that was a nice feature that they followed up to show death benefit, because at least you can tell a patient, like, this may make you live longer, 3 out of 100 people. This was the cholesterol treatment trialist, trial. This basically pooled all these statin trials, both primary and secondary prevention, so people who'd already had a heart attack and people who were at higher risk, and kind of gave us these this absolute risk reduction of 0.8%, number needed to treat of 125. And then this is really what I think has been propagated forward, is this, for every 40 milligram reduction in LDL, there seems to be roughly a 20% cardiovascular risk reduction. The caveat, again, it's relative risk reduction. So we're trying to drive everybody's LDL as low as we possibly can these days. And I was kind of drawn to the question then of like, well, what is a meaningful absolute risk? To me, I don't know. Shabauer and I were talking about this last night because it's not straightforward. I think it's probably individualized to some extent, because if you told a patient, like, here's a drug for $300 a month and you absolute risk reduction of 1% and you might have these side effects, they might be like, I don't know if I want to take that. Versus it was 50%, that's huge. Sure, I'd probably spend the money for that. And I think the other thing we need to emphasize too is what metrics are really meaningful in these trials that we're conducting and basing clinical decisions on. Is it all-cause death, cardiac death, MI, unstable angina, hospitalizations? We'll kind of get into the weeds of these. So this was a recap. Oh shoot, it went black. Sorry. So if you guys want to fill out the second question, which is basically a review of case 1 and how you would comment to a patient. And again, spin, right? It's subjective depending on how you want to tell somebody the data. So okay. I wish I could show you guys, but basically from the first time we went through this, 50% of people put 40% risk reduction. And the second time, 30% of people put 40% risk reduction, 30% put 20%, 14% put 2 to 3%, and another third commented clear as mud. And I think that truthfully exemplifies where I've been at to some extent, because I feel like you go through all this stuff, you learn a ton, and maybe you don't understand it as well as you think you do, and you see it through rose-colored glasses, and we know what's best, and we're just pushing these things always on patients, and maybe there's more impact that we could have in other directions. So just to show us again kind of the risk reduction you can expect from statins, and I'd like to point out that the mortality trials were really the ones driven by moderate intensity statins, which were Pravachol and Simvastatin, and then from there it was kind of the rat race of, well, who can lower cholesterol more and inflammation more and driving maybe softer outcomes like myocardial infarction. So this is a multi-billion-dollar industry. I don't think we can forget that. But now we've kind of entered this new era of LDL lowering, and PCSK9 inhibitors, whether it's through a monoclonal antibody or this new small interfering RNA, which is Leqvio, or bempedoic acid, which is just a drug that inhibits cholesterol synthesis upstream from statins. And then we have Zetia. So that brings the next question, because you're seeing this gentleman and he's not at goal. So when we talk about goals, the guidelines are getting more and more aggressive with LDL lowering in people, particularly with secondary prevention, meaning they've had a heart attack. So our guy from case 1 had a heart attack, and his LDL goal probably should be 55 or less, So what would you tell him in terms of his cardiovascular risk of dying, or just dying in general, with his LDL already at 77? Okay, the majority are saying 15%. I like it. 2% said 7%, and a third said 30%. Okay, that's good. So just to dive into where these things kind of evolved, PCSK9, some people are genetically deficient in it. And when you're genetically deficient in it, you have higher levels of LDL receptors, which means you can traffic LDL out of the bloodstream into the liver for excretion. So these people were shown to have fewer cardiovascular events, so that became kind of the emphasis of personalized medicine, right, is to try and target specific things in individuals. And so drugs were developed for this. And our first thing to note is the outcomes. It's not just cardiovascular death, and I'm sorry that's small up there, but it's myocardial infarction. I can't even read it here. hospitalization for unstable angina, coronary revascularization. So a lot of different endpoints, and you're like, well, that should be valid, right? Like, well, it didn't meet cardiovascular death, so that's the big driver patients want to know. I'm going to live longer if I'm taking a drug. Can't really say that from this trial, right? And this is the outcomes trial for Repatha, but it did lower myocardial infarction and urgent revascularizations and elective revascularizations. And here's your risk reduction, 15%, relative risk or absolute risk reduction of 1.5%, number needed to treat 67. So 1 in 67 people may have a fewer MI or revascularization, which those endpoints seem, I think, valid, but as we go through, you'll kind of see maybe the subjectivity of some of these endpoints. So this is a great article. Anybody that's prescribing maybe to be thinking about these composite outcomes and what are we driving. And at the center of this is cardiac death, but there was an evolution, a change in how trials were being driven and conducted, and it went to softer endpoints because otherwise you'd need way more patients or bigger drugs to really show a benefit, and it's hard. You saw with statins alone 3.3% risk reduction. It's not tremendous, so to get more on top of that, so we start doing these composite outcomes, and we go throughout the spiral here, and we get further and further out with different metrics to drive trials. But because it's in a composite with cardiac death, it makes it look like, oh, saving your life, this might be helping you. And this is what Repatha was driven on. And again, it's not that it's a bad drug, and I think that definitely these drugs all have their use. It's just how we're conveying it, and maybe how aggressive are we getting and for what outcome, and how are we explaining that to patients, because ultimately what we give them, we don't deal with the consequence of it, right? Like, I don't suffer the ramifications of somebody taking a drug that I give them. They do. And I think that's important to always be mindful of. So here's our next one, was the Praluent Odyssey outcomes. So again, big composite outcome driven by, any coronary heart disease event, major coronary heart disease event, any cardiovascular event, not cardiac death. And these events, how this stuff is defined, I mean, you go to this supplement and you just see how all over the place there's so many criteria, and we'll go into these a little bit more. The one thing I did want to point out, though, is that this trial in the secondary endpoint drove a death benefit of all cause. And, it's like, well, it's just lowering cholesterol. It shouldn't be helping all-cause mortality. And so I wanted to give a shout-out to Matt Gross, who was noted to be commenting on This Week in Cardiology podcast. And Dr. Mandrola gave him props on there. I thought that was pretty impressive to hear. So, and I think Matt is an awesome resource in general, and Roger, to take advantage of diving into things and understanding more of like why we do what we do, and getting to the heart of it. So this has been a big paradigm shift, right? With stenting, we always thought like, oh, we'll just put in stents and people will live longer and do better, but that hasn't really panned out. In fact, the data has kind of shown that it really doesn't always help in stable ischemic heart disease. So just because you have an 80% blockage doesn't mean you're going to do any better than if we put a stent in and fix it. So that was from the Courage trial with just mild ischemia on a stress test. Then finally the ischemia a decade later or so comes out with moderate to severe ischemia on a stress test. No benefit with fixing those blockages in stable ischemic heart disease. And so you're like, okay, well, that's a pretty big paradigm shift. Like, then ischemia CKD right after. There's no benefit in advanced kidney disease patients. And then revived BCIS was in heart failure patients with blockages, and just revascularizing them with stents didn't pan out. So then when you start thinking about all these composite outcomes, like one like elective PCI, well, is that really a positive outcome? Like, we're shown kind of through all these trials that fixing those elective blockages doesn't make them do any better. So what are we really doing? And then the not all plaque is equal. So tomorrow at Grand Rounds, I'm going to show a case that I thought was pretty interesting. But we had this trial series come out called the erosion trial, which showed that we don't necessarily have to even put stents in all heart attack patients that are acutely having events, because is it plaque erosion or plaque rupture? And it's been shown that you can medically manage a lot of these plaque erosion heart attacks. And so that kind of makes you even question more, like how aggressive do we really need to get with the drugs, in my mind. But the other one I think is the biggest is the troponins. And what is a heart attack, right? We have those NSTEMI classifications, 1, 2, 3, 4, 5, and like an example would be somebody comes into the hospital septic, they're 80 years old, and they've got downsloping ST wave changes on their EKG, and their trope goes from 100 to 300, and everything resolves. They feel great at their hospitalization, discharge, but somebody decides because, well, they had a heart attack, we should probably go cath them now. And you're like, okay, so you go cath and you find even an 80% mid-LAD. What's the temptation, You're going to want to fix that. And you go back to the stable ischemic heart disease data, and you're like, well, it didn't help anybody really to any huge extent, especially making them live longer. So that guy came in with sepsis, basically declared with a stress test because he was so sick, that he's got a blockage and ischemia, but you don't know if fixing that's really going to make him better. So all this is so counterintuitive. It's taken me a long time to wrap my head around. So if everybody's like frustrated with me, I've been there. I totally understand. And I think this is the other caveat, right? Are we willing to accept these risks? And I don't know the right answer with this, but I definitely take some pause when I think about routinely putting people on. Like one example would be as anti-drug antibodies. So this is at 78 weeks, 1.4% of people have these. The efficacy of the drug didn't seem to change, but what does it mean when you're getting these antibodies to a drug? And the SPIRE trials were they were PCSK9 inhibitor, but they were a human antibody combined with a murine antibody, so it was very reactive, and the trials had to be stopped prematurely. So it's kind of like, are we a little early on at 78 weeks to really know what's going to be going on? And there may be updates to this too. I don't know for sure. This one, though, really, I think I took pause on is statin-induced myopathy, because this is a really quite a serious deal, and I was completely shocked when I had my first patient with it because it's cited as being so rare, and she had to go to Mayo Clinic, get put on IVIG probably for the rest of her life, and so she's got this inflammatory myopathy from statins. And then just over the subsequent 2 years here, I picked up 2 other patients. So I'm going 3 in 3 years at a city that doesn't even have 100,000 people. Like, just, it's kind of odd. Maybe there's more to this, and the guidelines really are kind of recommending not even checking it unless the CK level's over 10 times the upper limit. But it kind of makes you wonder, and I'd be curious to hear some of the older docs that have been around, prescribing these, is like, have you guys checked them for lower levels of CK rises? Because we tend to just stop it and hold it and see if it goes away. And what have people been doing with that? This is our send out for Mayo Clinic, but in these statin-induced myopathies, HMG-CoA reductase antibodies are only positive in like a third of people. So, and there's nuances to all these tests, but in general, it should just be kind of a take pause, think about it. Now we've got inclisiran, which new technology, seems quite efficacious. It's an siRNA, basically inhibits the synthesis of PCSK9, so instead of using an antibody to block it, you prevent it from ever being made. And you got a 50% LDL reduction. No outcomes data yet, though, but we're using it. And we're using it based on that cholesterol treatment trialist panel, which is like for every 40 milligrams drop in LDL, you get a 20% cardiovascular risk reduction. Where to go with that is I'm still wrapping my head around, honestly. This is the part, though, I want to highlight is high ASCVD risk patients, high cardiovascular risk patients. Primary prevention, at risk, though, for having events were included in this. So just bear that in mind for a moment. Next, we're going to jump to bempedoic acid, which is Nexletol, an ATP citrate lyase inhibitor that also lowers cholesterol synthesis. And, cholesterol lowering is like 20-25%, so it's not very robust. But here was their outcomes trial, and I'm drawn. Good Lord, I can't even see it. I can't remember the numbers. I feel like this slide moved. Oh, okay. You want to share them? Oh, you've got them in yours. Oh, good. I forgot you were presenting on this. So the big thing is it wasn't driven by death, but events. And again, these are secondary prevention patients, and it also included high-risk primary prevention patients. So when we go to the supplement, because people are always, I think, captivated by this myocardial infarction, which we kind of just went over the data, like it's hard to know really definitively always what an MI is. And this, to me, I'm struggling with a little bit is, so their outcome was driven by a combination of fatal and non-fatal MI. And you have to go to the supplement to find, well, what was the fatal? Because that's really what probably you want to know about. And when you get to the supplement, you find that the fatal MI didn't drive it, but the non-fatal did, and we already kind of know the subjectivity with non-fatal MI, and so would that number even pan out? But the fatal MI, the hazard ratio is really kind of high, 2.4. I don't know what, I was going to pimp Roger on that later and get some data here, because let's see what he makes of that. One of my mentors from back in Ohio had told me this, and it kind of resonated through, is that not all science is good science. All numbers can be manipulated. Every study, whether positive or negative, should be hypothesis generating and confirmed, reconfirmed, or disproven. And I just wonder if maybe we're rushing in a little bit. Maybe we're just too quick to want to really help people. And are we always doing the right thing? And this is a Nexletol bempedoic acid trial for primary prevention, not people that have had CAD, or cardiovascular events. But you see what drove it was cardiovascular death. And I just can't help but take pause and think like, well, how did it help people so much to cause a death benefit in primary prevention? They haven't even had a heart attack yet, but it didn't do that in secondary prevention. To me, I don't know, and I listened to a lot of the podcasts and read a lot of articles with one of the authors to try and see, like, could he help me understand this? And I never really got it, and it didn't drive coronary revascularization. I don't know. I'm a little torn, and I don't know if they're outside here either. Maybe they can help us answer this. I put this in here because I think it's always about chances, right? So this was our COVID elopement wedding, Megan and I, and we're on Alex Johnson, and there's a lightning strike in the back, and that lightning strike, it happened to take out the power to our photographer's house, and she had to leave because her kids didn't have power and they were scared. So I don't know. What are the chances that happens? I'm not sure. But I also think I'm kind of like, well, if in secondary prevention there's no mortality benefit, but in primary prevention, people who haven't even declared themselves yet, a mortality benefit. Well, what are the chances of that? I don't know. And then the other thing to remember with primary prevention from this RENA data is these risk scores that we use to even determine if somebody is truly high risk are imperfect, and they overestimate risk quite a bit. So the blue is what their true cardiovascular events were, and the red is what we estimated it to be. So we're overly optimistic, trying to risk assess people, and we're giving them these drugs, and then somebody's telling you there's a death benefit from it, and you already know, like, you're overestimating the risk, and I'm getting a death benefit? Like, how is this? And then just to remember that the majority of people, like 80%, fall within this similar range of LDLs that have heart attacks or cholesterols. So cholesterol is definitely a factor, but it's probably not the main driver. And, I kind of been having an existential crisis to some extent and falling back on some of the old philosophers. But, 2 ways to be fooled. One is to believe what isn't true. And I'm kind of leaning that way in that instance. We'll come to the other part next. But I think that this was definitely another egregious example of how we can harm people. You remember Baycall? Where's Durr? We got an old fossil here. There he is. All right, the old fuddy-duddy. This drug came out, and it was making like $500 million plus a year, and was associated with a lot of harm. And when I was rereading on these articles and just kind of going through it, again, it's like, what are we doing here exactly? Like, we really need to be thoughtful about this, because we do have the potential to harm. And, with William Osler saying, the good physician treats the disease, the great physician treats the patient who has the disease. and I feel like it needs expanded on a little bit to, if we just espouse guidelines, we're potentially going to cause harm. And that's been my personal inclination now, is to be mindful and voice the risk and to talk through the trials with patients and to try and really let people know what they're getting into. And especially when you have things from like the late 90s to early 2000s, with the intensive, the lifestyle heart trial with Dean Ornish showing plaque regression, absolute risk reduction that's similar, fewer cardiovascular events. You had Predimed, we had the Lionheart trial, and Esselstyn showing that you can reverse disease. I mean, when you're seeing nuclear perfusion defects resolve, you're seeing angiographic changes. I mean, this is pretty profound, and it's kind of like, well, why isn't our emphasis there? And trying to help people on a deeper level. I think we're starting to recognize with statins, or with cholesterol being part of it, but not the whole thing, is inflammation more of a key. And I think this is what dietary changes really do, and this is what clinical trialists are showing now, with Matt Budoff really kind of spearheading this with cardiac CAT scans. So the Evaporate trial was with Vasipas showing plaque regression, which is an omega-3 fat, EPA, and aged garlic extract, which is odd. I'm like, how did he pick that? But the brand called Kyolic, and showed plaque regression. And then we have the pharmaceutical industry coming up showing cardiovascular risk reduction with things like colchicine and canakinumab. In the CANTOS trial was, it showed risk reduction, but it was also associated with some harm. So again, if we can do stuff more naturally, should we be focusing on that? And I think this is the second part of this quote, is, are we kind of refusing to not believe what is true by just giving people pills because we're taught to do that or told, and we're not being critical? And I think that was the beauty of medicine in general, was like that we got to be critical and scientific and challenge each other. And I don't know. I just wonder if we're kind of going off base now a little bit. And I think that this is a question that's reasonable for all of us to pose to ourselves, is, are we stewards of industry, or are we stalwarts of public interest? And I really hope that we find ourselves in the public interest realm. But I wanted to throw one more question at you guys here. So if you're a guy in case one, based on everything we just went through, what would you answer? And again, there's no right or wrong. So the majority are in the, I would pursue wellness changes and add one of the drugs above. 10% said they would just do wellness changes, and 14% said they would do Repatha. And I think that's awesome. It's good to hear. So here's Dr. Teixeira. I just wanted to give him a shout out, because he's kind of the one that pulled me over to recognizing that maybe drugs and the way we talk about statistics aren't necessarily always the most valid. So I did want to bring up some other books, things to consider. And, I think everybody's got a different spin on stuff, and I think it's always good to see the counter arguments to what you believe. And, these books, like The Big Fat Surprise, Nina Teakoltz did a phenomenal rendition of showcasing kind of how did we even become how did we divert from meat to all of a sudden plant-based oils, and where did cholesterol, and how was all this stuff kind of coming up through Ansel Keys and the seven country study. Ultra Processed recently came out. It was a really good book. Just how is the food industry manipulating food to target us? What are all these chemicals and things going in? And Hooked is an awesome book. Michael Moss has several out, but kind of how the marketing, addictive aspects of food really come to play. And Metabolic Goals with Dr. Lustig. It's a great read for a different perspective on kind of eating to heal and how we think about things like cholesterol. and I also would caution all of us, like, should we know the darker side potentially of our, and dark may be the wrong word, maybe that's glib, but we do have the potential to do wrong, and I think these books kind of showcase that. With that, I kind of leave it open for questions, and I hope I didn't bore everybody to death, but stats are always a tricky one to talk through.
I got the first question.
All right, you get the first one.
Hi, how is, are you weighing in HDL and triglyceride levels? And how does that fit in?
Yeah, I think that's a great point. So, from like AIM High, there wasn't a benefit with like niacin trying to raise HDL, and there was several other drug classes that were monoclonal antibodies that came out that tried to raise it, and they were negative trials. But I think when you look at the triglyceride to HDL ratio, if it's over 2, probably getting into that metabolic syndrome type state, and as the triglycerides are going up, the HDL is becoming less functional, smaller, and it definitely is a harbinger of risk. It's just kind of like, what do you do about it? Well, you can't really give a drug to help. You exercise, you avoid processed refined foods, which seems too simple. It's got to be a pill, right? We got to find a pill for it. So.
So if we're trying to avoid the statins and all the drugs, what do you want us to do naturally to try and help these people that we could be educating them on as nurses?
Yeah, I think that's a great point. And, the more you read into diets, and everybody's got a different spin, right? And really, if we just think back to times when we probably didn't have a lot of heart disease, or we look at tribes around the world, like the Hadza tribe in Tanzania, who still eat the way they've eaten for thousands of years and don't have the disease, and they eat meat and they eat plants, we're probably just overthinking it, right? But we are products of habit, and we're Americans, and we want what we want. And the food industry knows that. They love it. They engineer the food perfectly to accommodate that and to make sure that you eat a larger volume of it, And I think if we just keep it simple, like what did we eat historically? Smaller portions, not as frequently, and if it's, kind of like Michael Pollan, eat plants or eat food, mostly plants, not too much, you're probably going to do pretty well. But I do think you guys, especially in South Dakota, will find the big fat surprise interesting from a beef perspective. I've had a paradigm shift there too.
Let's pick the question. Can you repeat the question?
Oh yeah, so am I pro meat? And I would say that I'm definitely, I was kind of more on the vegan track, and I mean, Esselstyn and Ornish's data and showing plaque regression it speaks for itself. You can see it. So yeah, I think that route works. I don't think it's really hard to implement entirely, and I've always been fascinated by a case I had here of a 103-year-old lady that hadn't really ever seen a doctor, and she lived on a ranch, and she came in with a heart attack. And I'm like, holy shit, like 103 years old, and she's been growing up, meat and dairy and just the farm, and here she is, 103. And so I personally don't think anything is wrong with beef. I think that we've seen a shift in how beef is made, right? We grain feed, we give antibiotics, hormones, so we fatten it up to make it taste good so that you eat more of it. And I wonder if maybe, and I'm one of my fellows actually in Ohio, his family owns a ranch in southern Ohio, and we've been buying their beef, but talking with him about, do you guys have to grain feed them? I mean, like, if we just paid a little bit more because we're going to eat less, and why do you need that? When you grain feed something, you change the fat composition, so it goes from predominantly more omega-3 fat to more omega-6 fat, and omega-6 fat is highly inflammatory. It's kind of the precursor to all of our prostaglandins and inflammation. So, and inflammation, as we know, is probably a huge driver, which is now you're going to see a big surge probably in companies trying to target inflammation with drugs. We'll see what that looks like, but sorry. Yeah. You said it, though.
So one of the questions, I guess John's got one, but let me ask a quick one. How do you get the time? Well, it takes time to modify behavior.
Yeah.
And we talked about this last night.
Yeah.
So it's, if you have in primary care 10, 15 minutes with a patient, do you refer them out to some coach to do the work, or do you just end up writing a prescription so you can get them out of the room and tell them it's going to be good for them?
Yeah, I mean, unfortunately, I think it's always a mixed bag, right? When you go in the room, like some people you can tell are wanting to be interested and to hear and to learn and to educate, and there are other people though that are just, they're not gonna adjust anything about what they do, and they just are looking for the pill. And I think you kind of appropriate that when you go in the room and you're talking with them, and you give everybody a fair shake. But I think there's certain people you're probably going to be more apt to be like, you're really high risk, you're eating McDonald's, like you're working in fast food industry, breathing in all those fumes, which more risk factors. Like it's just there, I'm probably going to be more likely to say like, we should probably use medical therapy because that's all we have, and to really try to help you, versus somebody else giving them time, slow and steady, more frequent visits if you can. I think nursing involvement is awesome too, and everybody really has a story and might connect with somebody on a different level, and if it's you doing it or me, it doesn't matter as long as the patient's getting better, So if that helped answer that.
What is your take on omega-3 supplements?
Yeah, I mean, we've kind of gone away from it overall, because there's always, the trials have kind of indicated a higher signal for atrial fibrillation. We don't know exactly why. So over-the-counter supplements, I tend to say just stay away from, because we don't know if it's helping you or not, unless maybe they have a severe hypertriglyceridemia issue. But in general, you just don't know what you're getting, right? Like these food companies or these supplement companies aren't held to the same regulations. So where'd the fish come from? Is it already oxidized? Is it filled with other fats? Is there mercury in it? Like, it's just, I had an attending tell me once that Americans have the most expensive urine, and it's because we're always looking for the quick fix, and we'll buy whatever, to just help. And it's like, well, what is that? Oh, it's natural, it's fine. And it's like, well, natural to who? I don't know. Like, but.
Yeah. I'm a disease manage educating nurse, and I just want to give a good, appropriate alternative to those who don't like fish.
Yeah.
So, I mean, is it still safe enough, or you say
I mean, it's
probably not go that way?
I would just say if they want to take it and they spend the money and they want to do it, that's fine. I just can't guarantee, right? We don't have any good data unless it was with Vasipa, which isn't cost effective really. But that was, EPA purely, and it's bound to an ethyl ester, so it's very stable, and it's conjugated so that it gets activated in the liver and sent out to the body. And it's processed in a really cold, low oxygen environment. So like what you're getting is real, and there's data to show plaque regression and cardiovascular risk reduction. So I think in that instance it makes sense, but over-the-counter stuff, you just don't know how much you're helping them. Are you just eating to their pocketbook? I mean, you want to think you're helping them, and I think that's the thing with all the drugs, right? You want to think you're helping somebody, but maybe sometimes we're not. And yeah.
I had just something to say, Dr. Hatanelas, over here.
Oh, sorry. Gotcha.
Mona Saney, I'm one of the family practice docs in Custer, and I see a ton of patients out there, and I really appreciate your focus on not always just going off of algorithms and guidelines, because I feel like sometimes in the specialty realm, this is me primary care talking, I feel like you guys get stuck on that a little bit. Not you per se, but just those in general.
I'm guilty.
So I do appreciate that perspective, because we see those patients all the time, whereas some of you guys might see them every 6 months, and we deal with a lot of the myalgias and the arthralgias. And I've only been in practice now for 5 years, but I've had my first acute necrotizing myopathy due to rosuvastatin. And this guy came, and it was such a shocking case, because he came to me and they said it was rapidly progressive Parkinson's, but it didn't act like it. And he ended up actually going to Colorado, and they diagnosed it. He's doing very well now, thankfully. Wow. But that was huge, because even though that's not common, it's like if it happens to you, it's terrible. Yeah. And the other, my whole problem with lipid lowering medications also is the increased risk in blood sugars and diabetes. I have a couple patients on Repatha who've had 2 points increase in their A1Cs. And I feel like that's not always talked about with them either. And it's like, actually hyperglycemia puts you at increased cardiovascular risk too. So it's like, we're lowering one thing and raising another in some cases. So I think it's way more complex than just getting that LDL down below, 70 or 55 or whatnot. So I just wanted to say thanks for putting that perspective out there from a specialist to everyone.
Yeah, definitely. John.